So I'm going to do a brief overview of crisis assessment and interventions. Um, there are 4 basic crisis situations, and because this is an audio review of all of the material, I'm going to ask a question, just give you a minute to think about it, so that you can really start to see if you've integrated the material yourself. So first, I'm saying there are 4 basic crisis situations. So asking yourself, can you name what the 4 basic crisis situations are? Okay, well, there's 2 different dimensions you can think about. Well, of course, harm is involved in all of them, but you can think about the dimension of harm, someone getting harmed, and you can think about the dimension of abuse across time. So on one side of harm is harm to self, and the other side is harm to others, so suicide or assault. And on one side of the abuse continuum, you have child abuse, and on the other side, you have elder dependent abuse. So you can, you see the really little kids and the really old ones. Additionally, so those are the 4 basics, and you need to know the most about those. But other issues that could come up and might come up in terms of questions on the CPSE are medical illness or problems, which can include eating disorders, or you can also have intoxication or withdrawal from a substance. So we do actually need to know to some degree about symptoms of medical problems. No, we don't have to be doctors, but we do need to know a little bit. Additionally, acute psychosis is definitely a state that can warrant a crisis, and it might not be a suicide situation, but the person could be putting themselves in danger. And if it's delirium tremens, for example, they can go into seizures and die as a response, which is also a drug withdrawal issue. Grave disability, of course, is the other. If we were going to say there were 5 basic situations, at least in terms of the CPSE, you need to know about grave disability. And what does that mean? What's the definition? Well, it's an inability to adequately provide for one's food, clothing, or shelter. And these patients must be hospitalized. Also, in terms of the medical, anorexia and bulimia can actually be potentially life-threatening, so that can be a crisis situation as well. Now, intimate partner abuse, there are not the same abuse reporting laws as there are with kids and elders. However, something like a gunshot wound, stab wound, broken bones, things that need immediate medical attention, we need to be able to deal with that. And then when you're thinking about crisis assessment intervention for the test, they want to know that you as a clinician not only know what a crisis is constituted by a crisis, but you know how to deal with a crisis. And that means 2 things. 1, you have the knowledge to address it, understand it, intervene. And 2nd, you have the skills. So you can know all sorts of stuff, but if you don't have the actual skills in your repertoire, you're not going to be very useful. So what sorts of knowledge and skills? Well, fundamental to therapy is this ability to establish a therapeutic alliance. And because crisis situations, you don't have a lot of time, that's a really crucial skill for a crisis situation, that you can really quickly get in there and make that connection with someone so you can start dealing with the issue. You need to really be skillful in assessment because, as we've just said, you need to know if it is in fact a crisis or not. So there are stable and dynamic risk factors. So there's ones that change over time, and there's ones that are more static and stable. You want to know about, when you're assessing, here are other risk factors. You want to know the demographic variables. In terms of suicide, always want to know both ideation, intent, plan, and means, comorbid psychiatric disorders and medical disorders. Different assessment approaches. Clearly, you can interview the person that's in crisis. If you're there with them, that's patient interview. But let's say they're so psychotic, they're there with a family member, or they're there with their teacher, or who knows what, and they're not very capable of articulating what's going on, that would be a collateral interview. If you happen to be in a situation where you can review their records or give them testing, that might also be appropriate. That is not always the case, but it depends where you are. You also want to be hooked up to where you are in your community. You want to be connected to your community so that you can refer them as appropriate, whether it's for medication, to the hospital, any sort of emergency or additional support necessary. When you are assessing and intervening, need to be able to include family as appropriate. You need to know if you should hospitalize. So we've talked about the risk factors. We'll talk more later about what are risk factors in terms of demographics, etc. But you know that those are things you want to find out about. So what do these risk factors tell you? Well, you want to be able to know from your assessment if someone needs to be hospitalized, whether it's a voluntary or involuntary hospitalization. You want to be able to include the family if it's appropriate to the situation. And you want to know how to reduce immediate risk. So if you have a suicidal patient, you want to make sure, for example, that the means for suicide are removed. If you have someone who has some suicidal ideation, for example, you want to increase session frequency and generate contingency plans. Let's say it's not to the point where you would hospitalize. You also want to know, so we've talked about having the skills, talked about having the knowledge, and how to deal with it in the moment. But you also want to know about long-term treatment. So short-term is this directive, crisis-focused piece, and it very much emphasizes problem solving and skills building. So they want to know as well that you as a clinician can do these things that are important for crisis, even if you're a Jungian psychoanalytic therapist. They want to know that you have that flexibility, that you are competent if you, as someone who is sanctioned by the state to be a clinical psychologist, that you are not going to do a dream analysis if you have someone going through alcohol withdrawal and could have seizures. They want to know that you're also capable of handling those sorts of psychiatric emergencies. And that is part of what makes you a psychologist, is that comprehensive ability to deal with all things psychological and to really be able to be a resource across the board, whether it's a crisis or long-term therapy. So what is the difference between short-term and long-term? Well, long-term, you probably would address the underlying problems. And short-term, if there's some sort of underlying problem that could be addressed very, very quickly, then sure, that's part of your problem solving. But, if we're talking about an addiction, that's going to take time to work with. And that would be a more long-term thing. And as always, know about culture and diversity. And as always, know about law and ethics. So why don't you ask yourself here, what are different things that you have to know in terms of crisis, in terms of law and ethics? Okay, well, law around crisis, you're thinking here now about suicide and assault and abuse, and what happens when you see that? Well, you might have to report. So CPS, you might have to report child abuse. You need to know about hospitalization, because we're talking about people who could be a danger to themselves or others. And you need to know about involuntary versus voluntary hospitalization. And when we're talking about potential harm to others, the duty to warn is a really big one to know about. So know about that. And we're going to talk just a second about strategies. So think to yourself again, what are the 4, maybe 5, if you want to go the extra mile, types of crisis situations? Okay, so when you see suicide, assault, child, elder abuse, or grave disability on the exam, when you see that, we want you to start thinking about these questions in terms of, okay, here we go. Here's one of these 5. What's relevant vignette information? So that could be the patient's appearance and behavior. That could be their history and their diagnosis. There's the actual statements they make, and collateral statements and descriptions. So what, their husband who came in with them said. So one possible way of dealing with these questions is actually to make a note to yourself of, all right, what information do I have here? Because if you can really parse it out in your notes, and get clear with yourself, you're going to be less likely to fall for their tricks. And you're going to have just kind of a more objective view of what's going on. So here you have the information, the vignette information. What do you need to start thinking through? Okay, so you see it's a crisis. Here's the situation. You want to think, all right, what is the level of risk? Number one, what is the level of risk? Number two, what else needs clarified or assessed? And that's important because some of these questions may want to kind of push you or trick you into, saying, all right, let's involuntarily hospitalize this person, because there's that extra kind of leap that you can see could happen. Like, oh my God, this person could be manic. Well, if it's really not clear and doesn't seem like the person's a high level of risk, then you might say, hey, you know what, there's more assessment that's actually needed here before we can determine what the appropriate treatment or intervention is. And maybe that is referral to a medical doctor if it's not somebody who is at serious risk for immediate harm, for example. Additionally, this is where the piece of, no, we're not doctors, but we do need to know medical to some degree. What you need to be able to distinguish between a medical and a psychiatric emergency. That's really important to be able to do. And finally, similar to always thinking about culture and diversity issues, you want to think about your legal, ethical responsibilities and limitations here. If someone said, I'm going to go punch out my coworker, would that fall under duty to warn? No, probably not. So think about how, what you are able to say and do and to whom. So these are things you think about. So as you're taking the test, when you come to a question, there are 4 different sections on this test, right? So there's the crisis, there's the clinical assessment, there's treatment, and there's law and ethics. And yes, the questions will overlap, but you might want to actually make note to yourself and run through very quickly with each question, which of these 4 categories does it hit? So is there a potential crisis here is one thing you might want to ask yourself when you're going through the test. Is there a potential crisis here? Are there legal and ethical issues here? Those are some questions. But once you do determine that it's a potential crisis situation, we didn't do it with numbers fully before, but I'm going to ask now, what are the 4 different things that you want to look for in the question? Okay. 1, vignette information. 2, assess the level of risk. 3, clarify if you need more further assessment. And 4, distinguish between medical and psychiatric emergencies. And actually, I guess the 5th would be looking at the legal, ethical responsibilities and limitations here. So that's actually more like 5. Okay. 22% of the test on the CPSE is crisis assessment and intervention. The CPSE is California's opportunity to really make sure that new psychologists have the skills and knowledge necessary to practice independently. The board wants to make sure that the public is protected, and this means not only assessing that the psychologist knows assessment and treatment, but in particular that they know crisis assessment and intervention. And that's when there could be danger to self or others and grave disability. So to really be competent as a psychologist, it's essential that you know how to deal with a crisis situation. The tasks of dealing with crisis, there's 5 primary tasks that a psychologist needs to be aware of. Determining whether it is actually a crisis. So really fundamentally, is it a crisis? Being able to assess the risk factors for both suicide and for violence, and then to assess for grave disability. So you have determining if it's a crisis, you have the assessment, and then you need to be able to respond to whatever the crisis is. So these are pretty basic tasks. Is it a crisis? What's the risk factors? How do I respond? These are the things. And in terms of risk factors, harm to self, harm to others, and grave disability are the three big ones. So what knowledge does a person have to have? Well, there's a lot of knowledge that you would have to have as a psychologist. Basic knowledge of crisis assessment, of course. What are different factors? The medical, developmental, psychosocial, legal, environmental. And really just take a minute to brainstorm off the top of your head anything that someone would need to know in terms of how to deal with a crisis. Just really think about this, right? You need to know how to deal with the person so that, and what's going on. That's the assessment. Does a lay person really know the difference? Maybe, maybe not. And what are these different kinds of crises that you see? So a layperson might see someone freaking out and have no idea what to do, but you as a psychologist who are well trained might say, oh, those are signs of delirium tremens, or nope, that psychosis, it looks like it's a drug withdrawal psychosis versus a schizophrenia, blah, blah, blah. Now, how do you make that assessment? Well, you need to know about, like I said, medical, developmental, all sorts of different factors. And you need to know the different kinds of behaviors that people can exhibit in a crisis. Know when you need to consult, when you need to refer. And it's always going to come up that you need to know culture and diversity specific factors. So you almost don't even need to memorize this, because anytime you need to know about something, you need to know about the culture and diversity issues, which is a very good thing. What else do you need to know in a crisis? Well, in that crisis, there's also some finding out you're going to have to do. So you're going to need to learn about that particular person's history, clinically, demographically, any risk factors they already have or means they have. So you need to find out about this person in particular. And you need to know the techniques to find that out. Whether it's collateral interviews or psychometric procedures, you need to know about the emergency and community resources available to you, so you know how to call CPS if that's what's warranted. You know how to get in touch with the police if that's what's warranted. And you need to know so you find out what the person's risk factors are, but you also need to know what that risk factor means. What is really the biggest risk factor in terms of successful suicide, for example. And then you need to know the legal definition of grave disability, signs and symptoms, how to determine it. You need to know different strategies for intervening in all these different crises, and what your legal obligations are, of course. What are your ethical responsibilities? And, well, you need to know when you're done. You need to know as well how to include the family and how to follow up as appropriate for the situation. Finally, in talking about crisis assessment intervention, I just want to outline very quickly what skills and knowledge the clinician must possess. And we've gone over this, so see if you can first list them for yourself. So thinking when the clinician first must establish, I'm giving it away. When the clinician must first deal with the crisis, what must they do? That's right. They need to establish an alliance. And now here they are working with the client. What else must they be able to do? Well, they need knowledge. They need knowledge of what? Risk factors is one. What kinds of risk factors? Well, both stable and dynamic changing factors. What else must they know about? They need to know about assessments, different approaches. What else must they know about? Well, they need to know about resources. So they have to know about risk factors, assessment, and resources. Now, what skills do they need to have? They need to be able to include the family. They need to be able to assess for hospitalization. And they need to know specific interventions to reduce immediate risk factors, such as taking a gun away if there is a risk of suicide or assault. Finally, know about law, ethics, diversity, and short-term versus long-term treatment interventions. Okay, you also want to know about crisis, the characteristics of a crisis, and reactions. So the components of a crisis and the crisis origins. What is the definition of a crisis? Okay, thinking to yourself. It's a period of psychological disequilibrium, and it's experienced as a result of some sort of hazardous event or situation. It constitutes a significant problem that can't be remedied by using familiar coping strategies. So, not balanced, something happened, and old coping is not working. What are the 5 components, according to Golan, of a crisis? Hazardous event, vulnerable state, precipitating factor, active crisis state, and reintegration. What about the crisis origins? Well, there's 2 different kinds of crisis origins. Can you name them? The first is situational, and the second is maturational. The first situational is sudden, uncontrollable sort of thing, usually physical well-being is threatened. Maturational is embedded in a developmental process, like a transition from childhood to adulthood. What are the symptoms of a crisis? So you want to know crisis symptoms, and you want to know them in different realms. What are different ways in which a person can display symptoms? Okay, they can have affective, cognitive, behavioral, or physical symptoms. What are examples of affective symptoms? What are examples of cognitive symptoms? So here you can start thinking through PTSD. What might you imagine? What might you imagine in terms of if someone was in shock? So you can see confusion, impaired memory, concentration, decision making. Behavioral. What are some behavioral symptoms? So thinking this could be situational or maturational crises. What are different things you might see? Well, yeah, I mean, people might be less capable of accomplishing basic daily living activities, work-related duties, and you might see an increase in substance abuse, more impulsive and dangerous behaviors, and you might, of course, see a social withdrawal happen. So finally, what about physical symptoms? Well, just think, what are physical symptoms generally that people say will reflect on someone's emotional and mental state? Clearly sleep, clearly appetite. These are both things that are pretty frequent. When you think about panic attacks, what do you think about? Palpitations and dizziness, sweating, hyperventilation. And I think muscle aches probably we don't think about as much. Nausea, diarrhea, and constipation. I think we think about people getting kind of sick to their stomach when they're really upset. And then finally, a heightened startle response, which is a physical symptom, the fight or flight kind of startle response. Impact of culture. So, what could be the impact of culture in terms of a crisis? In what way could that influence how you think? Well, it can actually influence whether an event even precipitates a crisis or not, right? Different cultural meanings mean that it will impact people differently. What else can culture influence? Well, it can influence how we express things. So in that case, how someone is expressing themselves, it's important to understand their culture in that way. And how else does culture? Well, our cultures influence how we interpret our own symptoms, right? So that also is significant. And finally, if we have a different interpretation, we might respond to help in different ways as well. And what about reactions to a crisis? What are the different ways people can react. So we're going to talk about phases. So this is reviewing what we've just been over, but phases of a crisis, symptoms of a crisis, risk factors, and then understanding anniversary reactions and the impact of culture. So phases. There's 3 primary phases they talk about. Can you name them? The first is impact. The second is recoil. And the third is the post-traumatic recovery. And a lot of people are actually studying now post-traumatic growth. And what did we just talk about in terms of 4 categories that you might see symptoms? That's right. Emotional, affective symptoms, cognitive or mental, behavioral, and then finally physical. And what about risk factors? So you want to know, there's actually another way to group risk factors, right? So we've talked about demographic as one way of looking at risk factors, but there's also pre-event factors, peri-event factors, and post-event factors. So, did they just lose their job and then they were caught in a tornado, right? Like, did something happen before that puts them in a more vulnerable state? Peri-event factors, what was going on at the event? Were they alone or were they with somebody that they loved, right? Like, let's say they got the diagnosis of having cancer and this sent them into a crisis situation. Well, one event factor would be, well, were they with someone who loved them that was supporting them and holding their hand, or were they kind of by themselves? That might be one example of a factor to consider. And finally, post-event factors. So let's say they just got in a car accident. Did they, was there immediate help, blankets, ambulances, or was there not? So there's different things that can influence to what extent it's a crisis and even if it becomes a crisis at all. And also knowing about anniversary reactions. So people tend to have things come back up for them when there's anniversaries. So if you were to name 10 different things of everything we've talked about so far, which has been, kind of repetitive at times, what are required knowledge and skills that you as a clinician need to have in order to be competent in your practice and in your profession? Okay, here comes a crisis. What do you have to do first and foremost? That is correct. Number 1, establish an alliance. Okay, now here comes our knowledge. So what do you need to know about? Let's say there's 3 things you need to know about. Let's group them. 1, risk factors. 2, how to do assessments. What kinds of assessments are appropriate for who and when. And 3, additional resources that you can refer the person to. Okay, so those are 2, 3, and 4 on our list, confusingly enough. But anyway, so you've got alliance, knowledge, and then what else? So now we know we have the alliance, we have the knowledge. Now we start moving into the skills in the moment. 1, can you include their family? And 2, do you have the skill to assess for hospitalization? This is a big deal because whether it's voluntary or involuntary, there's a lot of cost, both in terms of money, whether someone is hospitalized, and also in terms of if they are not hospitalized and they should have been, the death or extreme harm that can result. So there's a reason that particular assessment skill is really important, because come crisis is when you're talking about harm can happen, right? So it's really important to be able to know whether the hospital is or isn't necessary. So you have alliance, you have your knowledge, you have your skills, which are so far the family and the hospital. And another skill, the third skill we're going to talk about here, is can you reduce immediate risk factors? Getting rid of the gun if the person has suicidal intent, or whatever might also be appropriate in that moment. So, skills, family, hospitalization, and dealing with risk factors. Okay, so we've made our way through the first 7, which were alliance, knowledge, and skills. And then the third the fourth piece to know about is more just what are things you need to consider in all of this. And you need to consider, as you do all of the time, to be responsible and good clinician, the cultural diversity issues, and the legal and ethical responsibilities. So those two you're just always going to see, and that is true again here. There are definitely a lot of legal and ethical issues that come up when it comes to crisis, because we're talking about suicide and 5150 and grave disability. We're talking about all sorts of things that are very much entangled with law and ethics. And the other one to know about is just what is part of short-term care and what is part of long-term care. So we have the alliance, we have knowledge that you need to have, risk factors, assessment, resources, we have skills, family hospitalization, reducing risk factors, and then finally we have the general considerations as a clinician of culture, law, ethics, and whether the intervention is in fact meant to be for the short term or the long term. So that is the overview. Those are the top 10. And in some ways, it's actually interesting because a lot of us do study our own field, whether we're in a cognitive behavioral school or an integrative school or union. And granted, that may color the way we interact with someone in a crisis to some degree, but there are really basic skills, because right now we're talking about getting a clinical PhD license, right? Like, we're not getting a coaching certification. We're talking about a degree and a license that can authorize you to be supervising other people, authorize you to be in hospitals, working with people, authorize you to be in this license really is saying that you have competency. And so as much as we might have our as much as one might be a clinician that's really focused on long-term death, Kleinian, Freudian, slip of the tongue therapy, that's great. And in order to have this license, you need to really be able to do what society has sanctioned that license as saying you're capable of. And that means that you need to know the DSM, and you need to know the difference between psychiatric disorders and medical disorders, at least far enough that you know when to hospitalize someone to get assessed by a medical doctor. You need to know these things because society is looking. That license says to a workplace or a hospital that you know these things, and so it's important that you do. And with that level of responsibility comes means that you're in a profession where you do really have to know what the law around it is. So, all that said, this is the intro to crisis assessment and intervention. All right, now moving into crisis assessment, domains, and types. So, quick overview is we want to know the characteristics of crisis assessment, the communication skills necessary, the domains that you're assessing, and the types of assessment you'll do. So we went over that this is what you need to know. Now we're going to go deeper into it. So what are characteristics of crisis assessment? Well, we're linked to resolution of the crisis. You're focusing on immediate and anything in the history that's particularly pertinent to the crisis. And this is an active collaboration where you identify goals and plans. So that describes what a crisis assessment is. The assessment and the resolution are actually quite intertwined. There are communication skills that you need, and we talked about the first and foremost piece of crisis intervention being a therapeutic alliance. Well, some will say there are 7 different elements of a therapeutic alliance. How would you describe those 7 different elements of a therapeutic alliance? First, being able to be silent. 2, being able to attend nonverbally. So these first 2 have to do with the nonverbal. Now let's get into the verbal. Can you restate things and can you paraphrase? So those are the verbal pieces. Now we'll get into emotion, ability to reflect emotion back to someone. That can create a lot more safety and containment when you're there present with them in that feeling. And finally, questions, knowing when and how to ask close-ended and when and how to ask open-ended. So we have the nonverbal, we have the verbal, we have the emotions, and the questions. So silence, nonverbal attending, restatement, paraphrasing, reflection of emotion, close-ended, and open-ended questions. Now press pause and see if you can name those 7 assessment communication skills. The domains of crisis assessment. You are going to want to assess for risk to life. So now we know the assessment domains, looking at risk to life, precipitating events, the manifestations in terms of interpretations and symptoms, and the systemic pieces. Now, what are the different types of assessments that you can do? And they might depend on the situation. Triage is the kind of assessment following a community disaster or other traumatic event, and it's conducted by frontline crisis intervention workers, otherwise known as first responders. You're obtaining the crucial demographic data, information about perception, coping, sources of support, safety, lethality. You're really going through everything. You want to know the mental status, symptoms, psychiatric conditions, environmental stressors, and ability to benefit from treatment. So the purpose here is just to determine, is intervention necessary? What is it? And you really want to be quick and thorough, but you need to know demographics, skill. You need to really quickly get through all of that stuff, but quickly and thoroughly. So do we need inpatient hospitalization, social service, support group, outpatient, and such? Okay, typical crisis assessment as defined by Roberts. The goals here are to provide a systematic method of organizing client information related to their personal characteristics, the parameters of the crisis episode, and the intensity and duration of the crisis, and then utilize this data to develop effective treatment plans. So an important aspect is distinguishing between normal reactions and reactions that are excessive and reflect a pre-existing condition or disorder. So you might be noticing at this point that there's a theme that when you're assessing crisis, a lot of people come into crises with things that have happened before, and not everyone was necessarily functioning so great before the hazardous event. So you are really piecing out what's normal and what's something that might be more chronic. There are different instruments available. Rapid assessment instruments are brief standardized self-report measures. You can administer them very easily, and you can then use them to monitor progress. Back depression inventory, for example. Semi-structured interviews have been developed for the purpose of crisis assessment. The triage model provides a framework for a semi-structured interview that involves assessing reactions on, the affective cognitive behavioral levels. The nature and the severity are recorded on a form, and the reactions that are identified as being the most severe are the initial targets for intervention. So first, the affective includes 3 types of reaction: anger, anxiety, sadness. Optimal interventions for clients whose strongest reactions are in this domain are the supportive strategies that validate their feelings, catharsis strategies, and awareness strategies so they can become more conscious. The cognitive domain is the perceptions of the event, and if this is the strongest piece for a client, you want to use strategies that help promote rational thinking, clarifying strategies to consider alternative interpretations, and delimiting strategies that help the client stop catastrophizing the crisis situation. Now, if the behavioral domain is the strongest, and that can be 3 different things. You're either avoiding, you're approaching, or you're immobile. So, fight, flight, or freeze. For these clients, you want to guide them to identify their resources. You want to protect them, whether it's themselves or others. You want to protect. And you also want to mobilize anything that can kind of come in to help them. Finally, the biopsychosocial assessment is used to obtain information on their biological functioning, psychological functioning, and sociocultural experiences that will be helpful for formulating treatment goals and a treatment plan. The amount of information you collect depends on several factors, including the severity and urgency. Note the amount of information collected from a client experiencing a developmental crisis may be fairly extensive, while information collected in an emergency situation can be limited to the identifying information, precipitating event, mental status, lethality, substance abuse, medical mental health history. So the really kind of bare bones needed information. And crisis test taking strategies. So when you're taking the test, identify when you're reading the question, is this potentially a crisis situation? Because if it is, you want to start thinking through what you know about crisis and crisis assessment. When you read the events, you can, highlight if you're studying, but you can jot down and kind of mentally highlight things like how they appear, behave, what's their history diagnosis, what are these statements they're making, collateral. Make sure you kind of identify what the key components in the vignette are. From there, you want to assess, from everything you know now, what is their current level of risk? Is there a further need for clarification assessment? And know the distinction between medical and psychiatric emergencies and the legal ethical responsibilities and limitations. So when faced with identify whether it's a crisis question, and if it is, look at all the pertinent information. First and foremost, always assess risk now that you know it's a crisis, and then start thinking through legal, ethical, medical, psychiatric stuff. Talking now about crisis intervention. So we're going to talk about the goals, how it's different from long-term therapy, what are the principles and tasks, and how do we evaluate if it went well. So the goals of crisis intervention, there's 5 goals. The first 3 have to be addressed, and the last 2 are only feasible sometimes. What would you imagine that you would absolutely want to do? Relieve the current symptoms. If they're psychotic, you want to get them out of that. You want them to see some of the factors that led to it, like, all right, you need to stop doing XYZ if it was something, for example, they were doing. And third, using whatever measures you have to restore them to their pre-crisis level of functioning. You cannot expect that they're going to make some sort of amazing gain and all of that, but you want them to get back to normal, whatever that is. Sometimes you'll be able to help them develop new coping strategies and connect it with past experiences. There are 4 different tasks, primarily physical survival, expression of feelings, cognitive mastery, and behavioral and interpersonal adjustments. So what about crisis intervention versus long-term therapy? What are some of the differences here? Well, in crisis intervention, we're talking about something very focused, and you're actually usually assessing and intervening at the same time. What's the focus difference? Okay, well, with crisis intervention, it's the traumatized aspects of the person. Long-term, more the underlying causes in the whole. What's the difference between treatment planning in either situation? Okay, what would you imagine with crisis intervention the focus would be? Yeah, it would be problem specific to alleviate the crisis symptoms. And in long term, what would the treatment plan be? It's personalized, it's comprehensive, and it's thinking about the needs of this person in the long term. What are different strategies you would use? In crisis, what would they be? They would be time-limited techniques for immediate resolution of the crisis. And what about long-term? In long-term, that might be the case that sometimes you would use time-limited, but you can also use things that address short-term, intermediate, and long-term goals. And how do you evaluate the results of either of these kinds of interventions? What makes a crisis intervention successful? You always want to think about if the person returned to pre-crisis state in terms of if it was successful. In terms of long-term, you actually want to see improvement in the person's functioning. So you don't want them to, be at the same state as when they entered. It's the same for crisis, but moments before, you're getting them just really back to their norm, whereas whatever their norm is for long-term therapy, you want their norm to change. What are the principles of crisis intervention? Okay. Just off the top of your head, you can pause this recording anytime you want, but just describe what you think a crisis intervention is all about, just from your being or heart. What is a crisis intervention about? And when you take that description that you've given of a crisis intervention, what do you see as some principles? So an example of a principle would be practicality. A crisis intervention is practical. So some others are proximity, immediacy, expectancy, brevity, simplicity, innovation, and practicality. So, something brief, here and now, simple, to the point. So the tasks of crisis intervention, as we reviewed already briefly, there's 4 primary tasks. And this is SLOCU. I don't know how to say it. SLOCU in 1984. So what are they? Again, just like when we looked at risk factors, you kind of look integratively. With intervention tasks, you're also looking at, body, mind, and spirit, basically. Well, maybe not as much spirit. That's always occurring. But physical survival. So, you want to make sure if they're anorexic, they get electrolytes if they need them, or if they're suicidal or homicidal, that appropriate actions taken so they are not any longer a threat to someone's physical safety. Okay, so physical. Second is expression of feelings. So identify and express the feelings related to the crisis itself. How are these feelings impacting them and their well-being? And then third and fourth, you're thinking cognitive and you're thinking behavioral. So cognitive means you're developing a reality-based understanding of the crisis. So whatever might be irrational here, or any unfinished business that's come up, you're addressing that and getting more reality-based. And in terms of behavioral and interpersonal adjustments, is there a way in which the person needs to behave differently and adapt to the situation, and hopefully minimizing any long-term consequences. So if the person is, so angry they found out their spouse is cheating on them, well, here you do want to make a behavioral adjustment. If they're about to leave voicemails for the spouse saying that they are going to hurt their child or something really crazy, that could mean they lose custody of their child. So even if it's not a physical, not 5150, but even if it's not a danger to other situation, in a crisis, you want to help someone kind of not behave in a way that's not going to actually make things worse for themselves later down the line, or in the moment, in fact. So what are the different models? There's 2 different models that you can think about here. The first is the stress crisis continuum. So it's Burgess and Roberts, 2005. They developed this continuum to help a clinician identify the type of crisis. And that will help you, again, choose the appropriate intervention. So if you want to pause the recording and just think about what are different kinds of crises that you have faced in your life. Thinking about the definition of crisis being something happened, there was some loss of balance. What are different things? There's situational crises, right? There's maturational crises. So what are different crises you've had? And now if you try to group them, or say, give them a blank crisis, it was a something crisis, or it was something distress. Okay, so here are the levels that they talk about. The first is somatic distress. The second is transitional crisis. The third is traumatic stress crisis. The fourth is a family crisis. The fifth is serious mental illness. The 6th is a psychiatric emergency. And finally, the 7th is a catastrophic crisis. And now, why are they put in this order? I think to some degree it's saying how serious it is, to some degree. So somatic distress, they are not feeling good. And what is the effective intervention here? Education about an illness or something to reduce, a medical treatment to reduce symptoms. Level 2. Can you remember what the second level was? That's a transitional crisis. This is something that's caused by a stressful event, usually anticipated but can't be entirely controlled. So if someone had a job transition or something like that, what do you do to help them? Well, just think, what is an example of a transitional crisis that you have faced, and what did you find helpful? So one thing is just preparation and knowledge about these transitions. Another are self-help groups. These are the kinds of things where having a community of others going through similar transition, or just some people that can listen to you and support you, can be really helpful. And then, of course, individual therapy can be helpful here too. And traumatic stress crisis, so that's our next level up, level 3. This is an external stressor, but it's usually unpredictable and sudden. So the transitional, you're about to retire, that XYZ is going to happen, but it's still a crisis for you. Well, traumatic, something overwhelming, life-threatening, sudden, could be a natural disaster or a sexual assault. What do you want to do here? In these moments, yes, long-term therapy might come down the road, but you want to do the crisis-oriented CBT. So get in there, get the person grounded and dealing with reality and able to respond to what they're facing effectively. Strategic solution-focused therapy, so similar lines, being strategic, focusing on the solutions. And then finally, pharmacotherapy can be really important here. So level 4, a family crisis. This is why I think personally the levels are a little silly. Who's to say which is worse than another? But to some degree, I guess you can kind of chart them out on this continuum. Levels 2 and 3 are actually pretty similar. It's like something happened, right? But level 2, it was perhaps more expected, even if still traumatic. Whereas level 3, you have these very serious, unpredictable things. But a family crisis, I guess you could see it as more serious, even though that's not exactly what they're saying. But these can be really long-term things. So you could have child abuse here, you could have intimate partner violence, parental abduction, homelessness. So this isn't just like something happened and now you deal with the fallout. A family system is a very sticky system, and usually what's been going on has probably been going on for a while. And those involved in the crisis are going to continue to be there. So if you were in a car accident, that can be very serious, but chances are you don't then have to continue meeting with all the people that were in the accident with you and hang out on that exact highway or something all the time. Maybe you do. I don't know. But here you have the family crisis, and homelessness is one too. So what do you do? What would you do as a clinician, or when you've had a crisis in your family? What are the different things, if it was addressed? What were they? What was done, and what was the goal? What's the objective here? So an intervention when it comes to a family crisis is you want to restabilize their lives, strengthen their relationships actually, and then deter any psychiatric symptoms that might come up. So let's say there was some sort of extreme intimate partner violence that happened and the kids witnessed it or something. It's saying here restabilize their lives, but I would imagine there are some family crises, and a lot of family crises, where there's precipitating issues building up to it. So I would think long-term therapy in addition. This is not in the book. Well, there are probably a lot of times where that would be important. That said, if the grandfather died or something, that might be something where it's not long-term therapy needed. But anyway, the goal is to help people restabilize their lives and, in fact, strengthen their relationships. So their relationships are probably hurt by this crisis, so how can they now be restored, and not only restored, but strengthened? So how can you do that? Psychoeducation, and then, of course, individual, couple, and family, different kinds of therapies can be helpful. So those are the first 4 levels. Now, 5 and 6 are when you're getting into more individual psychiatric problems. So level 5 is serious mental illness. So the dementia, psychosis, these things increase the likelihood that another problem is going to precipitate a crisis state. So immediate crisis intervention should focus on symptom reduction through enhancing problem-solving skills, environmental manipulation, and or pharmacotherapy. So far we saw that the drugs were suggested for psychopharm anyway. Psychopharm drugs were suggested for the traumatic stress and the serious mental illness. Family, transition, and somatic, that was not generally associated. Somatic, you might actually have medical treatment that's not of the psychopharm variety. Level 6 is a psychiatric emergency. So this is severe impairment. There is a threat of harm, whether it's to the self or to the others. We're talking suicide attempt, homicide, drug overdose. And because this is what we're getting to a really serious level, here you're talking about rapid assessment, mobilizing resources, and providing emergency care, right? Like, you're getting this person to the ER, you're getting the police there, you're going through your assessment questions quick as you can to figure out what's going on. And level 7, catastrophic crisis. So what could be, here we were at level 6 with psychiatric emergency. What's more serious than that? That sounded pretty serious. Well, catastrophic is a combination. So you're combining 2 or more level 3 crises with a level 4, 5, or 6 crisis. So, there's, let's say, an example would be, the person is going through, it's their final day of their job, they're retiring, so I guess that would be a transitional crisis. They're pretty upset, they're pretty vulnerable, and they were kind of so distracted, they ended up getting themselves in to a car accident, traumatic stress, and they're on the side of the road, there they are, they just were in this car accident, they lost their job, and all of a sudden they pull a gun out of their glove compartment and they're holding the gun to their head and threatening to kill themselves. That's, could be considered a psychiatric emergency. So threat to self. So that's level 6, a psychiatric emergency, and then you have level 2 and 3. So that is a catastrophic crisis, level 7. So that makes sense, right? It sounds like a making of an indie movie. They're retiring, they're getting in a car accident, pull that gun out, just seems almost ludicrous. So that's a catastrophic crisis, and what do you do? Well, here's what they say here, a comprehensive multimodal intervention. So a lot of different things coming at it from every angle. Okay, sure, why not? Okay, so that was a very thorough going into the stress crisis continuum. But I hope thinking about those 7 different levels of crisis can also kind of help you think through different risk factors you would want to know about, and what these different stages of assessment and treatment look like in reality, depending on these different situations. The stress continuum has 7 levels, and the 7-stage crisis intervention model consists of 7 stages of dealing with it. Now, what have I said continually is sort of the most important thing in terms of assessment and intervention? I keep saying therapeutic alliance, and that is still the case here to some degree. This model has you assessing them first, which makes a lot of sense to me. Of course, the foundation is going to be that ability to attend to the assessment and the intervention in a way that establishes an alliance. But anyway, crisis assessment is number one, evaluate lethality, evaluate the medical, and evaluate these risk and protective factors. So, for example, determine if the client needs medical attention or is thinking about suicide. Have they been the victim of violence? Are they under the influence of drugs or alcohol? So these are just those very basic things that you want to outline. And that really protects physical safety, so that's important. So then establish rapport, and we talked about different ways in which one does that. Then now you can actually sit and talk to them. They're safe enough for that. Identify the major problems. So what happened before the crisis? How is the client actually reacting to it? And what is their lethality, and what are their coping methods or previous coping methods? I can then have them build on that, hopefully. Also want them to explore their feelings and emotions. So have them tell their story about the crisis and express their feelings about it. This can actually really be helpful to just be able to use those nonverbal skills, that listening, and let them tell their story. One thing you can do as they tell their story is if there's any kind of maladaptive beliefs happening here, or if there's some behavior options that emerge, you can intervene, really gently, or, however is appropriate given the situation, to just shift those maladaptive beliefs. And if they're saying, oh, I'm going to have to tell that person off, or whatever it might be, you can say, okay, well, let's just hold on a second here and be here. And maybe there's some other things we can do. So you do want to slow that down just to helping restore emotional balance. So those are the first 4. Assess, rapport, what are the problems and feelings? And now you want to get to the last 3 stages where we're talking about moving into action. So 5 is generate and explore alternatives. So the client might sign a no suicide or no violence contract. That has its own issues, but we'll just talk about that for now anyway. Considering hospitalization. So you're thinking with the client, because it's a collaborative process, generally speaking, what can we do here? What are the coping mechanisms we can use? What are the resources and sources of support? This is what you do when you're in a crisis situation as a psychologist. So you've explored these things with the client. What is the next reasonable step that any person, whether you're a psychologist or not, would make after exploring alternatives? That's right, you would choose. So you develop and implement an action plan. So you've considered these things. Now you're going to implement them. And you're also going to promote cognitive mastery of the crisis, sitting there as the therapist with the client. So really, so they can kind of walk away with, all right, I understand what led to it. I understand what it means. So helping people find some meaning in it, and then replacing that maladaptive stuff, if possible, before they walk away, right? So this is how you're getting them back to pre-crisis functioning. So they were just in that car accident. They were shaking, they were crying, they were confused, all of these things. So now you've assessed it, you've established that relationship with them and kind of explored their feelings. Now you're able to kind of come to the point where they can say, okay, here's what happened to me. I was in this car accident. Here's the meaning of it to me. That was really scary. I realize how sacred life is now. I really want to go connect with my family who I miss and love. So they're kind of finding their way back to meaning. And if there were maladaptive beliefs associated, so I don't know, in this case, God, I don't know. I shouldn't have cursed out my coworker, I brought this on karmically or something that's probably not going to really serve them. Kind of say, oh, they've come more to a place where they're more, reality's more intact, and they can say, wow, it was really rainy and the roads were really slippery, and so they've kind of come to a better place. So the final stage is called follow-up. So this is it when you see, and it might not be you that checks, it just depends on the context, but it's checking to see if the action plan was successful by conducting a post-crisis evaluation. This could be a follow-up session, it could be at the 1 month or 1 year anniversary, or a periodic booster, having periodic booster sessions as needed. So, this description I was giving of somebody on the side of the road, you still might want to provide them with other resources and say, I really want you to go to this, let's say that this person seemed like there was, yes, they were at pre-crisis level to some degree, but that they might need checked up on, and say, go to this community clinic, go do a few sessions, give them those resources. So you can still try to put that in place even if you're not going to be able to follow up with them directly. Finally, we're going to just talk about crisis intervention methods. So this is the last thing that's up here. And you want to know both about the approaches that you can take and different sort of specific strategic options you have. So there are 3 different basic approaches. Now, if you think about yourself in a crisis situation, you might think about yourself as compared to different clinicians. Do you imagine there's any way you would be different than other clinicians who maybe went to different schools or had different background trainings or different personalities? What would be different about you? Okay, now picture yourself in different crisis situations. So one where you might have a homicidal maniac, as if, I don't think that's clinical, but let's say you have someone who's homicidal. Another where you have a little kid that's been found in the closet who is being abused. How do you picture yourself in these different situations? Is there a way in which you might be different? So this is how we're getting into intervention approaches, and we're talking about whether you're non-directive, collaborative, or directive. And they're really going to emphasize the different approach you would take depending on the client themselves. But I like to also just think about it in terms of that we actually do kind of have our tendency, perhaps even in our longer term work, as a way of thinking about it. So there's the non-directive approach. What would you imagine? When would that be appropriate? This is the case when a client clearly can actually initiate and perform things themselves. So what's the situation where that's the case? And what's your job then? So you're really becoming a facilitator and providing support and encouragement for this person. When might you use the collaborative approach? So this is kind of the middle ground approach. This is when a client can't function effectively completely on their own, but they still have some mobility, both physically and emotionally, to work together to resolve it. So the crisis worker is both a catalyst, a facilitator, they're consulting, they're providing support. And finally, the directive approach. When would you imagine this is appropriate? This is when they are immobile, physically or psychologically. They just cannot cope. It might be depression, it might be psychosis, they might not even know where they are. But in this case, the crisis worker is really actually taking responsibility temporarily for this person, defining problems and alternatives for them. And you provide them with instruction and explicit guidance as appropriate. So those are the approaches. What are different actual strategies and methods that you can use? There's 5 here. So what are different things you would imagine yourself doing? Kind of just think about it. Or what are ways in which you might work? Sometimes you might work with an individual, and sometimes you might work with a group or a family. Sometimes you might refer, and sometimes you might give first aid. So bolster their sense of safety during a traumatic situation. It's often necessary to refer clients in crises, especially if you've got medical substance abuse problems or maybe severe mental illness. So you could be referring them to an emergency room or a therapist. And of course, considering the law and ethics piece, sometimes you have terasoff type reporting. You might even have to enforce a restraining order. So that's the kind of one we don't think about too much, but that's an example of one. So these are all different ways in which you might have to intervene. All right, so we're moving into suicide assessment and treatment, and I'm going to do the really quick overview of risk factors and protective factors, and then you're going to hear a whole lot more about it and probably the same things. But first, I want you to think about what would you say when you're assessing for suicide are the primary things that you want to look for, and what category does that fall into? Okay. So there's two things that I think when we think about studying for these exams that we, and when we're working as clinicians, that we're always kind of thinking, we're thinking about the demographic characteristics when we're studying for the exam, and we're thinking as clinicians, for sure, I think it's been drilled into us from day one that you think about ideation, intent, plans, and means. So the suicidal actual natures of their thoughts and behavior. But there's other signs of risk factors that have to do with their history and then their current physical and emotional and situational factors. So let's just overview them. So first, ideation, intent, plans, and means. You need to assess the intensity and duration. How specific. Higher rates are associated with a specific intent and plan and with more lethal methods like guns, hanging, jumping. Drug overdose and poison is less lethal. Firearms is number one. So in 2010, 50% of all suicides were by firearms. So moving on. Previous suicide attempts and a family history of suicide is a big deal. Psychiatric history. More than 90% of people who kill themselves have a mental disorder, most often mood disorder. So that's important to know. It's been documented that about a third or more of depressed patients commit suicide within 6 months of leaving the hospital if they've been hospitalized for a suicidal kind of depression. The current mental status, not only are we talking about hopelessness and helplessness, but if they're not thinking well or hallucinations or delusions, all of these things increase risk. But of course, hopelessness is the strongest, more even than the severity of the depression. Physical illness is also hugely significant. Postmortem studies found physical illness in 75% of people who commit suicide. So not only 90% mental, psychiatric history, one study found 20% of older patients who committed suicide had visited their primary care physician the same day. So in terms of the demographics, men, white, older, divorced, and then married, of course, the lowest, and immigrant status. Finally, if there's a few social resources, if there's a lack of resources, that's not going to help. Or if there's a loss or an anniversary of a loss. And finally, protective factors are also there. So if you have access to care, family, and support, and then cultural religious beliefs that deter you, those are all protective factors as well. Suicide is not random or pointless, but rather it is seen as a way out of a problem or crisis that is causing intense suffering. It's associated with unfulfilled needs, feelings of hopelessness and helplessness, ambivalent conflicts between survival and significant stress, a narrowing of perceived options, and a need for escape. Suicide, however, is not a normal response to stress. According to the most recent data from the CDC, it is the 10th leading cause of death for all people in the U.S. Jeez. with 38,000 suicides in 2010. An estimated 1 million reported making a suicide attempt, with 25 attempted suicides for each actual death. Integrated into this section on suicide assessment are some of the other findings from the CDC. So let's start with what the goals are when you are assessing, when you're doing a suicide assessment. We are talking about determining basically if they're at risk. So is it immediate or is it in the future? And what information do you need to develop a treatment plan? And once treatment's begun, how do you monitor its effectiveness? So the initial assessment, you're going to integrate information from as many sources as you can, probably clinical interview, mental status, etc., for the goal of determining their level of risk. Okay. So now let's talk about actually performing that suicide assessment, actually. You want to look at risk factors. You want to ask them screening questions, and you might want to give psychological tests. So what are some risk factors to know about? Demographics is one piece, and that I think is pretty clear. Male, Caucasian, middle-aged, divorced men, 45 to 64 years old. These are your that's your risk factor package. Immigrant status as well is a risk factor. You want to look at physical illness. You want to look at psychiatric history. You want to look at their current mental status. So obviously you want to look at their psychology, right? So you want to know both historically and currently, particularly as it can relate. And you also want to look at what protective factors might be there. General risk factors include, so this is getting us away from kind of their history, but suicidal thoughts and behaviors. I think that's very clear. Certain psychiatric diagnoses, particularly depression, bipolar, substance, borderline. There's certain symptoms more associated, and what would you think those would be? Hopelessness, I think we all know. Severe and chronic anxiety can actually also be a risk factor. There's certain physical illnesses like HIV, AIDS, or neurological disorders that will up the chances. And finally, like we've said before, demographic characteristics. In general, the more risk, the fewer protective, the higher level of risk the person is at. Some risk factors carry more weight. So a very detailed and lethal suicide plan and the means to carry it out, is obviously very suggestive regardless of these other factors. So what are you going to do to actually get that information? You need to ask some screening questions. So you actually need to ask them directly, right? Like if we weren't clinicians, maybe we'd want to skirt around the topic. And yes, you're going to need to be gentle and appropriate based on who it is in the situation. But that said, you do need to ask directly. Do you ever feel like life isn't worth living? So you start with a general question like that, and then you're going to progress to be more and more specific. So if they say, no, it's not worth living, eventually you're going to say, do you have do you plan to kill yourself? Do you have a means to kill yourself? How likely is it? Whatever that might be. In terms of psychological tests, that would be, I think, clearly, that is always a standard. But not only does he have the classic BDI, but you have a suicide ideation scale and a hopelessness scale. And finally, there is a reasons for living inventory that you can use. So, suicide risk factors, want to think in terms of 5 different categories. Let's start with, when we think through suicide risk factors, let's just start with the most obvious one, which is, are there suicidal thoughts or behaviors? So that's very clear, right? And then we want to look at for 2, 3, and 4 in terms of suicide risk factors, we're going to look at, there's particular signs when it comes to diagnosis, symptoms, and physical and certain physical disorders. So certain mental disorders, depression, certain symptoms like hopelessness, and certain physical like HIV/AIDS. And then finally, demographic. I think we've covered so much that it's easy to remember that that's important as well. But let's create a perfect storm sort of picture. Let's say, and remember it in terms of the 5. Number 1, suicidal thought behavior. Perfect storm, they have a concrete, detailed, lethal plan and the means to carry it out. All right. Certain diagnosis. Let's say that this person also has a history of substance use and is bipolar. Number 2, let's say they are a former heroin addict and they're in recovery. So that was the substance use, and they are currently on meds, but they have a history of bipolar disorder. And now let's say that they are currently feeling, well, we know they have this plan. They are currently feeling hopeless, dysphoric, and very anxious. So those are the 3. So you can picture this person. And now picturing that actually you find out that this person also is HIV positive. And finally, you ask, you can assess, but you can also ask, how old are you, etc. And here we have a 52-year-old Caucasian male who just got divorced. His partner found out he was HIV positive and she was done with him. And actually, let's just throw in there that he's an immigrant from Germany as well, and he just came to the US 5 years ago. So this, let's call him Petrov. Petrov is our picture here of the sort of risk factor, the pinnacle of risk factors. And you will then ask Petrov some suicide screening questions, or you probably asked them that already to get to some of that. But you start general, you get specific. Let's say you give Petrov 2 Beck scales and the reasons for living inventory. And then we're going to move into treatment. And even without using him as our example going forward, I just want to let you know that Petrov actually did get great treatment. You did a fantastic job. And he is now living a very, very happy life. And he and his wife have reunited. And it all worked out very well, because that was a very sad picture that was just painted of poor Petrov. So I just wanted to wrap that up with just let you know that Petrov, you did a great job with him and he's doing all right. So what did you do? That's what we'll talk about now. And before we move on, just to kind of go over some questions you might get. This test is related to, so the board is actually under the Department of Consumer Affairs. So because of that, I mean, obviously we all care about our clients, people being safe and not wanting to see any suicides or homicides. That said, the Board of Consumer Affairs is very concerned about suicide and homicide. So you will see these on the test, and they want to make sure that you will deal with it appropriately and catch it. Here are some things they want you to do. As I just said, they want to know that you will directly inquire about harm issues, not, gently find out by, going around the issue. They want to know that you will directly say, are you a danger to yourself? Are you planning to harm yourself? Are you planning to harm anyone else? They want you to know that men kill themselves at 4 to 5 times the rate of women. So if you're asked a question and 2 choices are male and 2 are female, the answer's probably, almost certainly going to be male in terms of who is at more risk. They want you to know that older folks are at greater risk. It jumps kind of higher and higher. Now, while they say 45 to 64 is the highest, what I can tell you is sort of the most current data is when people hit 45, uptick 65 uptick, 70 uptick, and then 75 is this huge jump. So there's that. There's a CDC study, and for the CPSE, you want to pick white male. 70 to 75 age white males are the highest death rate. It's alarming and it is staggering. And that is actually pretty sad. So while the numbers run close together for white versus black males, it's still highest as white at every age, apparently. And then finally, when you were studying for the EPPP, you might have heard a very specific fact about a specific population, and I'm not even going to repeat it. Just know that we're talking about white folks. If you have an idea about perhaps it's Native Americans from the age of 19 to 34, just forget that fact for this exam, because that won't be the answer. It can hurt you on the exam. Suicide and diagnoses that increase risk. What would you say are the 5 top diagnoses that are related to suicide risk? Some of them were just named. They are, they might have picked up questions from Bruce Bomberg's book. There is a bias in the exam, and that is the word plan. If you were to commit suicide, have you thought about how you would do it? That being very indicative of the potential of there being risk. So what are the diagnoses now that you've had time to think about them? First, so we're talking about what people often associate as some of the more kind of serious emotional disorders. And just kind of want to highlight that those with thought disorders also have higher suicide rates. So major depression, yeah, there's suicide there. But when we think about really folks who are at risk, you want to think bipolar 1. But above that is major depression with psychotic features, because then we're talking about the sadness piece, the hopelessness, those emotions that tend to be related to suicide. And we're also talking about impaired reality testing, which would make it more likely that someone would take action. So first up is depression with psychotic features. Second is bipolar 1. And I think that's pretty easy to remember. It's pretty intuitive. And the third is when we have our personality disorder, and you can guess what the personality disorder associated would be. It's the one where there's a lot of cutting and a lot of threatened self-harm. The thing is, it's not just threats, right? Because the borderline personality disorder is the third one on our list, and they actually do follow through sometimes. So these are people who are in a whole lot of pain. And fourth, alcohol dependency. Again, I mean, this is just me talking, but there's some impaired ability to, some impairment in thought process and reality testing if you are under the influence. Can also increase depression. So that is number 4. And then 5th is schizophrenia and schizoaffective. When you are screening for suicide, there are 4 elements that you are screening for. What are those 4 elements? Okay, that's right. Ideation, intent, and plan is always the 3 that you go through, but there's also looking at behaviors. That's also important. And again, begin with their feelings about living, and then you progress to the ideation and the behavior piece. So it could be specific, like, have you been thinking about harming yourself? What would it be like to die? So you're kind of getting into death, suicide, self-harm. Now, if they say yes to these, that's when you start getting into the sort of more lethal piece. What led up to your thoughts of suicide? Well, how likely is it that you would actually act on that? Do you have a plan? What things would make it more or less likely that you try to kill yourself? Do you have access to guns or weapons? So that's the means piece. So for those who actually have attempted suicide or self-harmed, you would ask them, can you describe what happened? What was happening in your life right before the attempt? How did you feel afterward? Did you seek treatment or did someone else get help for you? Do you feel differently about harming yourself now? So you want to know, have they changed their mind, or are they going to be released from the hospital and just go right back to trying to hurt themselves? And as appropriate, you can follow up with questions that address if they're at risk for harming others. That might be more the case if there's some sort of traumatic event that involved other people that they're angry with and they're psychotic, right? And you might ask, are there other people who you think are responsible for how you're feeling now? Are there other people who you would want to die with you? What about suicide in law? It is never required. But that does not mean it is not a malpractice issue. So you are never required to report suicide. That doesn't mean that it is not your ethical obligation and best practice to protect clients from hurting themselves. So if you're seriously not practicing ethically and someone dies, that's malpractice, right? So just because it's not illegal doesn't mean that you can't be sued for not being a skillful, not even skillful, a competent therapist. When you're thinking about suicide risk and you're thinking through some of these questions, just remembering that it really is all about the plan piece. So obviously, if there's just ideation, that's your lowest risk. So what do you do? Well, what about a suicide contract? Is that a reasonable thing to do? Absolutely not. There will never be an answer where the use of a suicide contract will be correct. You are never, if you really think that someone is a danger to themselves, you are risking mayhem by sending them home with a no suicide contract. If that you set that and the client then kills themselves, legally you're in big trouble. Because if you're saying, the lawyer might ask you, hey, is suicide a rational act? You say, no. Would you sign a contract with an irrational person? And you say no on the stand. Then you basically said, so I signed a contract with a person I knew to be irrational. That's not going to look very good in court. And 1 out of 3 therapists will probably lose a client to suicide in the course of their careers. And so this is something you want to think seriously about. Two different psychological tests worth knowing about, both in your own practice as well as for the test, are the Beck scale for suicide ideation, the Beck hopelessness scale, and reasons for living inventory. Okay, so let's talk about suicide treatment now. Goodwin and Jamieson said there are 3 primary goals: safety, an alliance, and alleviating acute risk symptoms that you can. So that would be something like insomnia or panic. So these are the primary goals. Ensure safety, so you're getting rid of guns, you're developing trust, and you're alleviating symptoms like insomnia and substance abuse. Now, the secondary goal, however, is going to reduce future risk, and that's by addressing other conditions and risk factors. Okay, so those are your goals. What are your options or alternatives for treatment? You can categorize folks into 3 different types. Outpatient and inpatient are the 2 broad categories, but within outpatient, you have crisis intervention, and then you have outpatient psychotherapy. So for hospitalization, it's appropriate for a client who's just attempted suicide or is really at imminent risk. They have got the specific, as we know, specificity matters, so they've got the specific plan and they've got access to lethal means. Or impaired judgment, impulsive behavior, severe mental illness, chemical dependency, lack of support, all of these things that you know about already. You want initially them to voluntarily hospitalize themselves, but an involuntary hold should be initiated if they won't enter voluntarily. And then you've got the two different kinds of outpatient treatment. This outpatient crisis intervention is for the moderate risk, and outpatient psychotherapy is kind of is more of a follow-up or someone who's really at low risk for suicide. And that might just be that, there's some intent, but there's really no specific plan, and they've got lots of friends and they're willing to talk about it and deal with it. That's where psychotherapy would be most helpful. Moving on, so we talked about the primary goals of safety, alliance, and alleviating symptoms, and secondary of reducing future risk. The clinician really has to make the determination in terms of where to go. So that's part of your goal, is where can you actually be treated. So in terms of outpatient interventions, we have medical referrals as possible, safety contracting, therapist availability, all of these things. You can also include family members. You can both have some short-term plans and some long-term plans. So there's a lot you can do as an outpatient. But you want to really be aware as the clinician of any illicit substances, because that not complying with actual prescribed medication or taking illicit substances can make it pretty impossible to really move forward. Okay, so what's your plan if you are doing outpatient intervention? There are 1, 2, 3, 4, 5, 6 steps. 1, medication. 2, removing means of harm. 3, safety contract, therapist availability, and emergency plan. Now, Sharon Jablon says you should be asked to contract for safety and to commit to refuse. So yes, get them to commit to that, but do not do any sort of signed contract. That will not hold up in a court of law, and it will not be an answer on the exam. So, the therapist can increase availability, have more frequent sessions, create an emergency plan. All of these things are really good, but no suicide contract, no. So you've referred them for medicine, you've gotten rid of the means of harms and come up with kind of a safety emergency plan. Now you want to, if it's appropriate, pull in family members and significant others and kind of do things that are going to help. So enhancing their communication, and if there's any abuse, you need to find a way to prevent future victimization. In the short term, treatment of the patient is directive and crisis focused. If there was a suicide attempt, it can be reframed as a failure in problem solving, with the patient help to improve problem solving skills. So longer range, you're going to want to focus more on the underlying problems. So that can be both psychiatric and medical, and probably is both. Follow-up. Suicidal patients have high rates of non-attendance at follow-up sessions, so take steps to increase the likelihood, and that means setting a specific date and time, reviewing the goals, explaining why continued care is necessary, and if there's resistance, really address it now, because you might not have the opportunity to do so later. So that's outpatient. What about inpatient treatment? When risk is high, it's necessary to hospitalize. And what's the process? Well, voluntary first, and if refusal, involuntary. What would you say are the two goals for hospitalizing? Okay, so the first is you want to ensure their safety, because you can't really do that. If someone's really at high risk, you can't do that in another situation. And what is the second? Stabilization through medication, because if they are this severely suicidal, they really need some acute intervention to stabilize things. And that's not only medication, but also therapy and social support. But the medication really probably has to happen. in this kind of case. While most do respond favorably, some don't to this idea. And you may have to breach confidentiality. You might have to rupture the alliance to hospitalize. And yes, be as sensitive as you can. Try to understand what it means to the patient. Try to make it as supportive and collaborative. But if they're at high risk, it is the responsibility of the therapist to make sure that they are safe and hospitalized as appropriate. And you can do so legally. You can break confidentiality and all of that legally. However, there are some legal issues to consider. Working with a suicidal patient, 3 things to think about here. 1 is an exception to confidentiality. This is considered a safety emergency. And safety emergencies are exceptions to confidentiality. So the therapist can breach through that understanding, and it could be either the patient's family or to hospitalize. Ideally, this all happens with the patient's consent, and it should be time limited. So, just because you broke it once doesn't mean for the rest of time you're consulting with the mom or the roommate. So it's limited to and it's also limited to the necessary information that they need to have. So just because you're breaching confidentiality doesn't mean that you have to tell them that, they stole their roommate's earrings 2 years ago or something like that. Involuntary hospitalization, this is the 5150, and it is a 72-hour hold. After a 5150, it goes to a 5250 certification, and that's a 14-day hold. Following that, you can do a 5260, which is an additional 14 days. But that, however, is not renewable. So even if they are still suicidal at the end of that, they cannot be involuntarily confined anymore. So, there's 28, it's about 31 days, about a month someone can be held. Exception to privilege. Evidence Code 1024 states that there is an exception to privilege when a patient's mental condition causes them to be a danger to self or to the person or property of others, by the way. So privileged information can be disclosed to prevent the danger in a legal proceeding. So privilege being a legal term, right? So most commonly this occurs when there's a certification review hearing. So that's Evidence Code 1024. We talk about duty to warn a lot, and just be clear that suicide is never duty to warn. That's it. Okay, so now we're talking about danger to others, assessment and treatment. Violence and assaultive behavior is what we're talking about here. And they include homicide, so violent homicide, rape, assault, robbery. The U.S. Department of Justice and the CDC provide fact sheets about these crimes if you are interested. In fact, U.S. residents have experienced 5.2 million crimes of violence in 2004. Violent crime has been declining, and it's now less than half of 10 years ago. The perpetrators are overwhelmingly young, mostly majority under 30. Males are more likely. Blacks are at a higher risk of perpetrating than whites. Oh my goodness, the time is flying here. In terms of victimization, teens have the highest rate of being victims. 78% of murder victims are male. And let's see, in terms of the victim-offender relationship, males were equally likely to be violently victimized by a stranger or non-stranger, while females, it was much more likely to be victimized by a non-stranger. 7 out of 10 rapes or sexual assaults are by someone they know. In terms of kids who were murdered, 2/3 of these kids, it was by a parent or family member. So there's lots of stats here. School violence has been declining. What else? The West and Midwest are more likely than Southerners and Northeasterners. And in terms of alcohol, in about a third of stranger victimizations, the victims perceived alcohol to be a factor in it. And then in 2/3 of the intimate victimizations. So, all right, so how about assessing? A comprehensive violence assessment must include assessment of risk factors as well as the protective factors. And this should be obtained through at least interviewing the patient, but if possible, as always, reviewing the records and other providers, etc. That could be forensic records and probation officers in these cases. A scale that you would use would be the historical clinical risk management 20, the HCR 20 scale. Okay, this is very similar to suicide. You want to know about ideation, intent, plan, and means. So the more specific the intent and plan, the more likely. Mostly these majority happen with guns, of course. Another risk factor is, just like suicidal history is a risk factor, so is criminal history and antisocial attitudes. 2 of the top 4 include of risk factors are criminal history and the pro-criminal attitudes. Pro-criminal, weird. Psychiatric history, particularly antisocial personality disorder, is one of the top 4 factors. Intermittent explosive is by definition involves assault and or destruction. Schizophrenia. So most individuals with schizophrenia are really not any more dangerous than average folks. There is a subgroup that have a higher incidence of assaultive and violent behavior, however. And finally, history of family violence, childhood abuse is also associated. So that's in terms of the history. What about current mental status? Well, with suicide, we know hopelessness, helplessness. With violence, there's a poor judgment and impulsive piece. If there's negative affect of some kind, whether it's anger or fear, that also ups it. And similar to suicide, psychosis is increasing your risk. So psychosis, goes both ways. Demographics are different than with suicide. The demographic variables associated with greater risk are younger. So here we have males who are young, under age 30, of large build, non-white, poor, and with low IQ are the more likely to commit crimes of violence. Interpersonal relationships and lack of resources. The quality of your relationships influences aggression. So if you don't have social support, have lots of conflict, then that's upping your chance. Protective factors include access to, as well as involvement and compliance with effective clinical care for substance and mental use, or mental and substance use disorders. And anything else you could think of, like coping skills, working, school, all of these things. And also a fear of being hurt and punishment does deter. So that is assessment. In terms of intervention, you have to determine whether they can be treated similar to suicide. Can it be an outpatient treatment or does it need to be inpatient? When is it outpatient? Well, if there's not strong intent and there's really no plan or history, maybe it's just somebody who got fired from his job and he's like, I want to beat my boss up. I don't know, something like that. And they're willing to say, okay, no, I won't do it, and you've calmed them down. Their affect is now modulated. These are reasons you could handle it in an outpatient way. However, if there's a homicidal plan with lethal means, not good. Now, if there's a history of assault or criminal activity, even worse. And if we're talking about some serious psychopathology, impulsiveness, and poorly modulated affect, we are really, really thinking hospitalization, inpatient treatment. And of course, if there are no social support and nothing really stopping them, these are all reasons you would want to hospitalize. Outpatient intervention. So let's say we aren't hospitalizing. What does that look like? You want to refer for medication evaluation, remove the means of violence. These are also things you want to do a lot of the times with suicidal clients. You also want to do a safety contract, therapist availability, emergency plan. Same kind of thing. Involvement of family members and significant others. If there are not contraindications, you might want to find a way to reduce stressors in the environment, reduce conflict with others. And then in terms of the treatment, of course, you're thinking short and long term. So short term needs to be the crisis focused, similar to suicide. In this case, you're going to deal with anger management and assertiveness training probably. And you want to identify any specific stressors that are contributing. So if it's somebody cheated, how can you kind of separate them from interacting with that person? What are their high-risk situations? So if dropping the kids off at their ex-partner's house is a problem, you might want to find a new way for them to transfer the kid, although that's a whole other child issue if they're potentially dangerous. But in any case, you want to think through specific issues like that. And violent patients, as well as suicidal patients, have high rates of non-attendance at the follow-up sessions. So, same thing. Set specific time, day, explain why it's important to keep going. So it's a very similar process here. Inpatient. When risk of violence is very high, hospitalization is necessary. Of course, voluntary is offered as the first option. You're probably going to find that less often than with suicide, but there are many who will respond favorably. And it's really the same as with suicide here, though, that you want to first prevent danger and harm, and second, stabilize the symptoms. One thing we didn't talk about with the suicide is therapist safety, because here we have a violent patient, and at times that can mean the therapist could also be in danger. When a patient is angry, irritable, threatening, but not imminently dangerous, therapists can often diffuse the situation, and then set limits and all of these things. But therapist wants to be seated in a way that they are not between the patient and the door. They should never attempt to block the patient from leaving the room. And with a patient who's eminently dangerous and appears unresponsive to hey, step back, you might call 911, flee. You might even have to attempt to disarm them. So basically, you can do whatever you want to protect yourself. What are your ethical and legal issues? Here we have terasoff. That's the big one. That's a civil code, by the way. And you need to know about exceptions to confidentiality, exceptions to privilege, and involuntary hospitalization, which ends up kind of being related to the exception to privilege. Terasoff states that there is a duty to warn, protect, and predict in the following situation. Quote, where the patient has communicated to the psychotherapist a serious threat of physical violence against a reasonably identifiable victim or victims. Okay, so serious threat, reasonably identifiable. In this situation, the therapist must make efforts to communicate the threat to the victim and to the law enforcement agency. In the recent Ewing decision, the judge determined that a patient communication extends to information given to the therapist by a close relation of the patient. So it now means that if the patient's spouse tells you, that counts as under terasoff. What is the exception to confidentiality? If someone's homicidal, that's considered a safety emergency, and those are exceptions to confidentiality. So that's not terasoff. This is similar to the exception to confidentiality you have with suicide. You can breach confidentiality here, both to notify their family or hospitalize the client. Ideally, you can do these things with their consent, of course. And again, like suicide, limit it to what's necessary about the current situation. with the disclosure of confidential information. Involuntary hospitalization is allowed under the Welfare and Institutions Code. That's where you'll find that. And again, this is like suicide. It's a 5150. After the 5150, you can place them on the 5250, and that's the 14-day hold. Now, whereas with suicide, you go to a 5260 and do a second 14-day hold. Here with homicide, we're not talking about the person harming themselves. We're talking about something that could be more dangerous to someone else who doesn't have the ability to protect themselves. And now you go into a 5300, which is a 180-day hold, and that is actually renewable, unlike the 5160 for suicidal clients. So exception to privilege, just like there's an exception to confidentiality, there's also an exception to privilege here. And the privilege one is from Evidence Code 1024, just like in the suicide. And that's because the patient's mental condition causes them to be a danger to the person, property of others, or to the self. Love the property piece. That's interesting, huh? Thus, in a legal proceeding, privileged information can be disclosed to prevent the danger. Most commonly, this occurs with the certification hearing. So, ATAB's follow-up, legal and ethical issues are related to danger to others, and they say you need a comprehensive approach, look at the demographics and the psychiatric current and past elements, as well as the situation, past violent behavior, young age, low socioeconomic status are characteristic, substance, manic, antisocial, as well as neurological impairment, anger, and impulsivity are risk factors. Also weapons, lack of support, victim specificity are situational factors. Screen by starting with doing a two-stage general questions first, like when do you get mad? What's the closest you come to being violent? To then the specific ones. Are you thinking about hurting someone? Psychopathy checklist and the MMPI, MCMI are good screening tools. You could say there's low, moderate, and high risk, fewer risk factors, based on how many risk factors and the specificity, intent, and plan in terms of causing harm. Your goals are to build the rapport and reduce risk for future violent behavior. You might have medication, safety plan, all of these kinds of things. And what you do depends on how much of a risk you think they are. We're also going to look at grief. There are 3 types of grief, and you want to assess that the grief, it can be anticipatory, normal, or complicated. Anticipatory occurs prior to the loss. Normal or uncomplicated is, it can be shock and disbelief, sadness, depression, etc. Kubler-Ross has the stages of grief, the 5 stages. Complicated is also called unresolved or pathologic, and that is when normal is disturbed. There can be more isolation, violence, severe depression, PTSD, and such things. Your assessment goals, you want to determine how they're coping with the loss and to distinguish between grief and other conditions. So the main source you're going to use in clinical interview with the symptoms, mental status, etc. You might use the BDI-2, Brief Symptom Inventory, Acute Stress Scale, Impact of Event Scale, and then the DSM-4's GAF, potentially, though that might be a little outdated at this point. Treatment goals. With grief, you want to help them complete the grieving process, and how you do this depends on the type of loss they had, the severity of their grief, and if there are any coexisting problems. Some might need medication, therapy. For normal grief, there might be short-term meds and support groups. For complicated grief, you might need intensive grief-focused therapy and CBT interventions. Grave disability. Let's start with the definition. A gravely disabled adult or minor, they are unable to provide for their basic personal needs for food, clothing, and shelter. And this is because it is a result of a mental disorder or chronic alcoholism. It cannot be by reason of mental retardation or intellectual deficit alone. So, how do you assess for it? The primary goal is to determine, when you assess for it, is how much is the mental disorder interfering with their ability to function. In addition to clinical interview, whatever else you can do, a mental status exam and the GAF scale are good instruments for this. And when do you hospitalize for grave disability? If they cannot be managed in a less restrictive environment, and even if they have help of responsible family and friends, they still can't have their basic needs met, then that is when they should be hospitalized. Of course, voluntary first, but involuntary if they will not comply. And again, this is similar. This is the 5150, then the 5250, but then you've got some different stuff to follow that up. Let's talk about child abuse. We are required to report it. So let's talk about the assessment intervention, though. What are signs? So if you see bruises, cuts, burns, that's a sign. And if the child provides an explanation that doesn't fit, that's a good sign. Behavioral signs, though, are accident proneness, problems with schoolwork and peers, loss of interest, shrinking from physical contact. And this is especially if it's a sudden change. Other things can be delinquency, drug abuse, anorexia. If you see someone who's chronically overactive and hypervigilant, or super withdrawn, depressed, and overly compliant, these are all physical abuse symptoms. Sexual abuse is similar in terms of signs, but they also might be more secretive, bathe a lot, and you could even see they are more sexually provocative or promiscuous. You'll also see things like sleep disorders, anxiety, self-esteem, fatigue, low energy. So you see a lot of the depression stuff come in. And you can see pain and rashes in the genital areas sometimes. Enuresis, urinary infections, vomiting. So poor little bunnies, huh? What are risk and protective factors? Well, risk factors are those with disabilities and mental retardation, young parents, lack of family cohesion, there's violence, all of these things, low socioeconomic status. Protective factors are supportive family environments, nurturing parenting skills, stable relationships, there's rules, there's housing, there's role models. So, I mean, it's pretty obvious if you have a family that is supportive and supported, you've got less of a chance that there'll be abuse. How do you assess it? So, we are talking about interviews and testing and referrals. So interview, you want to interview the child. Don't ask leading questions to kids. So it's better to ask how a child got a bruise or what they're afraid of rather than have you been abused, right? Or have you been physically hurt? Observe them. So look for the physical and behavioral signs that we just described. You can interview the parents and obtain their views of what they think occurred. So that can also be interesting to see if there's inconsistencies between that and the teacher and the kid. Ask the parents how they discipline their child. That's important. In terms of interview collaterals, sometimes after you talk to the parents and the kid, it's still not clear. And that's when you would contact the teachers, coaches, and other family members. Or like the school psychologist, of course. If child abuse is suspected, but there is little evidence, it's helpful to have a pediatrician conduct an examination of the child in order to detect any physical or sexual signs of abuse. So that's really important to know for the exam, because there are questions on the exam where they're giving you a lot of information, then they ask if you want to act on it, and there's sometimes that option of getting more information. And here is one thing you want to do with physical or sexual abuse where you're not certain. Medical evaluations actually do apply here. Projective tests can also be helpful, like the Roberts apperception test for children. So if there's a preoccupation with abuse in the actual test, that's a sign. And so how do you intervene? ensure their safety, contact law enforcement or Department of Children's Services. And we'll go into law and ethics later, but I think you need to do within 36 hours. Refer the child for medical evaluation and treatment. Assess co-occurring abuse. So there might also be elder abuse in the home, domestic violence. Figure out if there are other victims. And then when you treat, you want to see if there's been any secondary disorders that have now developed, like mood or anxiety. Establish an alliance. This can be hard because the kids might not have a lot of trust, understandably. So you want to really help them with their self-esteem. Once they are safe, then of course you want to help them rebuild a sense of safety. And parents need to be educated about abuse. So that's that. In terms of eliminating future abuse, you need to work with the family and the Child Protective Services to reduce likelihood. So this can be parent education, parent skills training, and really also making sure that they have all the resources they need in terms of financial assistance and all these kinds of other stressors you want to help with. If it occurred outside the home, you do not want this kid to have any contact with the perpetrator anymore. Therapists can also work with the child to develop a safety plan so they can know what to do. We'll talk more about this, but child abuse reporting, we are legally mandated to report suspected child abuse to a child protective agency or local law enforcement. This is a situation in which confidentiality may be breached. Ideally, the child abuse report can be made with the patient's consent, in which case, of course, there's not a breach because you had consent. And limit it to what's necessary for the report. In terms of elder abuse, again, bruises, broken bones, complaints, etc. How do you assess? Interview them, observe them, interview collaterals, whoever, whether it's staff or a family member, and refer them for medical evaluation. How do you intervene? Ensure their safety. Contact protective services and law enforcement as necessary. Refer them for a medical evaluation. Assess for co-occurring abuse. And when you treat them, assess carefully if there is first a second disorder now. And to eliminate future abuse, you need to educate the family, get additional support for the family as needed. And they might also want to refer the perpetrators to anger management class. That sounds insufficient, but maybe it's not. I don't know. In addition to minimizing the likelihood of future abuse, the therapist should help the dependent come up with a plan of safety in the event that signs of abuse resurface. Additional crises or crisis situations. Medical illness? Well, yeah, so what would you think? There's other things where you need immediate intervention, and this would be medical primarily, and there's different aspects of medical. So it could be a medical illness, like an asthma attack, drug or alcohol intoxication withdrawal, which is also kind of medical, anorexia and bulimia. They need a medical evaluation. Gravely disabled patients need to be hospitalized. Acute psychosis, you need to figure out if they need to be hospitalized because you could get into suicide, assault, or grave disability here. And intimate partner abuse. If there's a gunshot wound, then they're going to need to get treated, and I think that's pretty self-explanatory. But all in all, these are important things to know about, both in terms of your clinical practice, but also if you ever find yourself sort of in emergency crisis settings.